Well, I obviously have to start off by saying thank you once again for inviting me to a Lynch Syndrome UK conference. For some reason you seem to find my talks worth repeating and inviting again. I don't know why, but you're a lovely bunch of people and I'm so thrilled to be invited back again. So just a bit of an outline for my talk. I've got a bit of a background and then I'm going to talk about learning from existing studies, which is going to be quite important because I haven't yet finished my study in order to tell you the results. And also looking at the relevant quality of life studies, because quality of life is one of the major factors that we need to consider here, and then the planned work. So a little bit of background. A new health technology, be it a drug or a test or some strategy, is cost effective if adopting it leads to improved health at a justifiable cost. So it doesn't have to be cost saving, it can cost more than what we currently do, but it has to be good enough to justify that additional cost. And when I say improves health, we normally measure health using something called a quality adjusted life year. So that will put less value on life that is lived if it is of low quality. So if you've got lots of pain, for example, or depression, or if you're unable to do the things that you want to do in your life. And these quality adjusted life years, or QALYs for short, are calculated by multiplying the length of life lived by a QALY weight, which is sometimes called a utility value, for the quality of life that is experienced. So the QALY weight, maybe I should just hold it. The QALY weight for perfect health is 1. So 1 year in perfect health gets you 1 QALY. The QALY weight for death is 0. So once you are dead, you stop accruing any of these QALYs. It is, well, yeah, it's not normally a laughter line, but it is considered possible to have health-related quality of life which is worse than death. People would rather end their life now than continue to live with that health. In that case, your QALY weight can be negative, so less than 0. Start with the cheery stuff. Okay. QALY weights can be obtained for particular health conditions in a number of different ways. So we normally will obtain them from people who have that condition, which is good. So we're not just asking random Joe Blogs off the street, what do you think it'd be like if you had endometrial cancer? Particularly difficult for Joe. So we would normally get them to value their current health state in some way, or we get them to fill out a questionnaire and then we give values to those questionnaire responses that we've found from elsewhere. So one of the ways that we can get those QALY weights is something called a standard gamble, and it reads something like this. You are offered the option to take a new treatment. If you take the new treatment, there is a 10% probability you will die immediately and a 90% probability you will live with perfect health for the rest of your life. If you do not take the new treatment, you will live with your current health for the rest of your life. So there's no impact on your life expectancy, it's just the quality of life, but then with the possibility of dying immediately. Sorry. I'm nose breathing onto it and it's just going, oh, terrible. This guy. And those bits in red can get changed until the point when you don't mind which of these options you go for. And at that point, we've worked out what value you assign to your current health state. Another way that we can do it is a time trade-off. So instead of saying there's a risk that you'll die immediately, we're instead saying you're going to trade off a known amount of your life expectancy in order to improve your quality of life. So we'll say you can either live for 10 years with your current health, or you can live for 8 years with perfect health. And after that, you'll die immediately. And you can change that number 8 until people find these equally tolerable, and at that point you've worked out the QALY weight that they would assign. Another way is that we can use a questionnaire like this. So on the left it's asking you about mobility, self-care, usual activities, pain, discomfort, anxiety and depression. And there are 5 levels for you to choose from for each of those. So you can say I have no problems washing or dressing myself, but I have moderate pain or discomfort. And based on that we can say, you know, you filled it in this way, therefore your QALY weight is 0.7. To find out if a new technology is cost effective, we look at the added costs and the added benefits. So it's got to be from one thing relative to another. And it will be found to be cost effective if, when you divide the added costs by the added benefits, you get an answer that is less than the threshold. And the threshold in the UK is £20,000 to £30,000 per QALY. So if something gives you the equivalent of 1 year of extra perfect health, the NHS is prepared to pay £20,000 to £30,000 on top of what it currently pays. Here is an example. I want to stress that the numbers are completely made up. So if taking aspirin for 10 years costs £1,200 and adds 0.2 QALYs, so the equivalent of an extra 0.2 of a year in perfect health, divide 1200 by 0.2 and you get 6,000. 6,000 is less than 20,000, therefore aspirin is cost effective. So this part of my job is the easy bit. As I don't need to tell you, people with Lynch syndrome have a higher risk of bowel cancer, so they are offered colonoscopy, a form of surveillance. Women and trans men with Lynch syndrome have a higher risk of endometrial and ovarian cancer, so they're offered, we'll just whip it out. So there's a disparity in terms of what's offered, and the question is why. So our aim in this research, as Helen's already shown in her presentation, is it effective and cost effective to offer surveillance for endometrial and ovarian cancer to women with Lynch syndrome? Now, in an ideal world, I would be here giving you the answer. Unfortunately, other work has displaced this work, and so I'm going to talk a lot more about the studies that other people have done. So there have been 3 studies so far that have looked at gynecological surveillance. They've all been in the US, and they have all been modelling studies. So we've heard about the organoid models, and we heard about the mouse models. These are just computer models, so they're less messy. But it is important to say that this is not the result of doing a study in real life people. It's a mathematical guess. And there have been 3 studies. 2 of them have looked at surveillance on its own, surgery on its own, surveillance then surgery, or doing nothing at all. 1 study just looked at surveillance alone or surgery on its own. The most recent study has also included a split surgery study where you get 1 surgery at one age and then another surgery later on. So removing the uterus first and then removing the ovaries later. These studies are all very similar in the approach that they've taken. So they assume that when you detect a cancer by surveillance, it has a better stage distribution. Earlier stage of cancer means better survival. And they assume that if they don't identify it through surveillance, it would present symptomatically in less than a year. These are the sorts of assumptions that go in, so key assumptions about the risk of getting cancer. The most recent one down at the bottom divides this according to the mismatch repair gene that is affected. We also have the cost of surveillance, which varies a bit across the studies, although that's mostly due to inflation. And then those quality weights that I was talking about earlier are shown here on the right-hand side, and there's a lot of just copying from each other, which we call science. So the earliest of these studies, by Janice Kwon and colleagues back in 2008, came to the conclusion that risk-reducing surgery at age 40 is the economically optimal thing to give people, because if you have the surgery earlier, it detrimentally affects their quality of life too much, and it's not worth doing. Whereas if you do surveillance only, you get much lower quality adjusted life expectancy and you spend a lot more money. And the idea of doing some surveillance for a bit and then doing surgery could be the best way of getting you quality adjusted life years, but it's too expensive to be justified. However, if we exclude the surgery options, so the one that says RRS at 30 years, RRS at 40 years and the combined strategy, and you just look at no intervention and surveillance only, then you would find that surveillance would be cost effective so long as your threshold was over $85,000 per quality. Kathleen Yang and colleagues in 2011, they didn't include a no intervention arm in their study, but they found that risk-reducing surgery was dominant over surveillance, so it would cost less and it would be better for you, which is a similar finding to what Janice Kwon and colleagues found. And Wright and colleagues, they, as I said, they divided it up according to which gene is affected. And they said if you are an MLH1 mutation carrier, then your optimal strategy is to have the uterus and fallopian tubes removed at 40, and then have the ovaries removed at 50. And the same thing would be true for MSH6. For MSH2, they would say it's economically optimal to have the uterus, fallopian tubes and ovaries all removed at 40. That's because there's a higher risk in MSH2 in their model. And for PMS2, they would recommend hysterectomy and bilateral salpingo oophorectomy at age 50. So you can leave it later because the risk doesn't show up until later. They didn't really focus on the idea of if surgery wasn't an option, but looking through the appendices, you can work out for yourself that for PMS2 carriers, surveillance would not be an optimal strategy, and that means it would cost you over $100,000 per quali gained. Whereas surveillance from age 30 or age 35 would be economically acceptable so long as you were prepared to pay $100,000 per quali. So the existing studies strongly suggest that risk-reducing surgery leads to better quality-adjusted life expectancy compared to surveillance alone. Risk-reducing surgery leads to lower costs compared to surveillance, and in people who are willing and able to undergo surgery, surveillance is economically unjustifiable in the US. Those studies also suggest, though perhaps a bit less strongly, in people who are unwilling or unable to undergo surgery, surveillance generates enough benefit to justify its cost, but only if you are prepared to pay $100,000 per quali, which is a lot more than £20,000 to £30,000. So that's what the existing studies tell us about surveillance. And now I want to talk about the review that we've been doing on quality of life, because it's really important to understand the impact of all of these things on quality of life before we can decide what is best for patients and what is best for the NHS, considering health benefits and costs. So we looked for studies to give us quality weights for endometrial and ovarian cancer, as well as gynecological surveillance and risk-reducing surgery. The largest study calculating quality weights for endometrial and ovarian cancer was by Kent and colleagues, and they found here that the average quality weight for somebody with no history of cancer was 0.73, so quite a lot of potential to benefit from improving their health-related quality of life if they could. Quality of life slightly lower than that at 0.7 for endometrial cancer, and then slightly lower again at 0.68 for ovarian cancer, though you'll see that the numbers are getting smaller and smaller. There's really insufficient evidence for endometrial and for ovarian cancer of the effects of disease stage, so we would generally expect that when somebody has a more advanced cancer, it affects their quality of life more. We didn't have enough data to support that, but that doesn't mean it's not true. There was insufficient evidence to tell us whether it would be beneficial to have keyhole surgery rather than open surgery, and we didn't get enough evidence to tell us about the impact of age. So those are all things we'd be quite interested to know, but the evidence wasn't really there. In ovarian cancer, we had lots of measurements from chemotherapy trials, which is good. But unfortunately, these are typically measured at the start of a cycle. Before you've had your chemotherapy, you've just recovered from your last cycle, you're feeling pretty good about life, and they measure your health. And then you have your next round, and they're not recording your health when it's at its lowest. The participants in these studies can also be unrepresentative, and they often don't measure using the best possible tools. So you have to do a mapping from a less good tool to a more appropriate tool. And that adds even more uncertainty. When we looked for studies on gynecological surveillance, it's fair to say that it's challenging to design this research appropriately. Do you ask participants to imagine that they receive the surveillance only once, and then that's it for the rest of their life? Or do they imagine they're having this annually? Or is it a continuous torment? And also, what do you tell patients about the benefits of surveillance if you're asking them to choose between surveillance and something else? You have to tell them why would you be having the surveillance? What are the possible benefits you're getting? So one study back in 2009 used vignettes. So this is somebody writes a bunch of text, and maybe it's accurate, maybe it's not. So there's an example of that on the right-hand side. So this is meant to be a description of having a vaginal ultrasound. I'll leave it up there just for a minute if anybody does want to read it to see if they think it seems remotely accurate. Probably my main concern with this is that participants are kind of including the risk of ovarian cancer in their valuation of the surveillance. So if you're asking them, do you want to live in this state where you might have ovarian cancer, or we've said you can have perfect health for the next 20 years, you'd be like, perfect health please, because I don't want ovarian cancer. And it's not necessarily the surveillance that they are shying away from, but it's the ovarian cancer that's associated with that description. A more recent study by Sun and colleagues also used vignettes, and they used a modified standard gamble approach. So instead of saying there's a 10% probability of dying, they just say there's a 10% probability of you getting gynecological cancer. So participants aren't told how effective the strategy is, so they might be assuming it's 100% effective. They're not told when cancer might affect them, or the chance that a cancer would actually lead to their death. So it's very difficult to take the results from this study and turn them into quality weights. Sounding a bit like a broken record, especially with my nose. Very limited data on risk-reducing surgery in Lynch syndrome. So there's 2 studies, one that I've already talked about and another one by Kupperman and colleagues. There is a lot of data on hysterectomy for benign conditions, and there's some data on risk-reducing surgery to remove the ovaries in people with BRCA mutations. So Kupperman and colleagues used vignettes yet again. Participants valued a number of health states, including undergoing risk-reducing surgery or not undergoing risk-reducing surgery but having surveillance. In that study, they asked both men and women to think about a health state where they undergo testing and then it comes back Lynch syndrome negative. They also asked men and women to imagine they were offered testing for Lynch syndrome and they declined it. And then the women only were asked to consider they undergo testing, they're Lynch syndrome positive, and then either they have risk-reducing surgery or they have gynae surveillance. And so those women found, or it was found, that there was a lower quality of life associated with being Lynch syndrome positive versus negative, and slightly lower quality of life associated with surveillance versus risk-reducing surgery. But there are issues with the study, pretty big issues in my mind. So one of the things is that Lynch syndrome negative one, they're described as basically having pretty good health overall, and they're still saying they think there's a lot of improvement to have, and we think that might be because in this study they are told that their sibling has Lynch syndrome following a colorectal cancer diagnosis, and so they might think they have the option to stop their sibling having colorectal cancer and Lynch syndrome. So the study's a bit funny. And that's not because they think that's something that could actually happen, but it's just a misunderstanding of the study design. It's hypothetical scenarios, and they're misunderstanding the comparisons they're meant to make. They also, when they're describing risk-reducing surgery, they say it completely eliminates your risk of cancer, but they don't talk anything about the adverse effects of that surgery. And they don't tell you how effective the surveillance is. Hysterectomy for benign conditions, lots of studies look at this. They generally find that your quality of life is substantially improved by hysterectomy, perhaps returning to your pre-disease baseline after a period of post-operative recovery. But these studies don't really tell us anything about surgical menopause in most cases. So surgical menopause happens to all pre-menopausal women who have both ovaries removed immediately. Some premenopausal women will also experience early menopause following hysterectomy without ovary removal. And the impact of surgical menopause will depend on the availability and effectiveness of hormone replacement therapy. Okay, so my planned work is to develop a whole disease economic model for Lynch syndrome, which will include diagnosis, surveillance, risk-reducing surgery, bowel cancer, endometrial cancer, ovarian cancer, to start answering these questions from a UK perspective, and hopefully including the best quality evidence on quality of life, although as you can see there is not a lot of good quality evidence on quality of life. So we want to know if it's cost effective to offer surveillance. So I want to improve on those existing studies by doing more realistic modelling. So rather than it being a case of you're somebody who has a cancer, we're going to know about it in a year's time. If you're in surveillance, you'll have it diagnosed in this stage distribution, whereas if you're not, you'll have it diagnosed in that stage distribution. It's a bit clunky and unrealistic. I'd rather have a model that includes things like precancerous lesions, a development over time, progression of the disease, better justified quality weights, and explicitly consider people who are unable or unwilling to undergo risk-reducing surgery. So plenty of reasons why people might be unsuitable to undergo risk-reducing surgery, such as fitness for treatment. They might have had previous abdominal surgery that makes it dangerous to have further surgery just for risk reduction. And also to consider some other edge cases, so when things don't work out exactly how you'd like, such as if somebody has a pre-menopausal cancer, they end up with surgical menopause, they might not be able to get the hormone replacement therapy that they would like. That's not really well enough represented in the existing studies, so I want to make sure our work does. The conclusions that we can take at this stage are that surveillance is unlikely to be cost effective if risk-reducing surgery is an option. Surveillance may be cost effective if risk-reducing surgery isn't an option, but that's not yet been confirmed in the UK setting. And if you look at the $100,000 versus the £20,000 to £30,000, it might give you a sense that it could go the other way here. I asked the question, does that create an ethical dilemma? If somebody really wants some surveillance now, they could say to their clinician, I am unwilling to have risk-reducing surgery, please give me the surveillance. And then in 5 years' time they say, now I'm willing to have the risk-reducing surgery. Do we need to account for that possibility? The existing research into those quality weights is really insufficient. And I think we've found an issue overall that the research in this area has not been of the highest quality, which is a real shame. So research recommendations, number one is Tristan, finish your damn project. After that, I think we need to have a careful examination of the observational data that has already been collected. And I think we need to investigate those preferences for gynecological surveillance and risk-reducing surgery in Lynch syndrome so that we have a better idea of what will actually give patients the best lifetime health. Because at this stage we don't even know that, because it's been so poorly investigated. Here's a slide of my references, and it's time for any questions. Hi, Kai King.
Two comments and a question. The first comment is, that was a fantastic talk about colleagues, and I think it's genuinely a great talk. The second comment is more about you looked at, there were certain mutations, right, that you had 73% chance of getting endometrial bowel cancer at the age of by 75. And then Helen showed some data that, you know, the pickup rate was 6% or 3% or something like that. Is it just because those studies that she presented did not go over, obviously, 50-year period of time? Because that, to me, that sounds like totally, you know, we should be doing some kind of specific surveillance for some of those patients.
Yeah, so it does depend a bit on how long you are surveilling people for. So if your risk to age 75 is, say, 50%, as is suggested here for MSH2, and you have it for, say, 50 years, age 25 to 75, you know, roughly divide a 50% risk by 50 years, there's a 1% risk every time you have a test. So that is sort of in line with the numbers that Helen was coming up with. So I don't think these are disagreeing, and I do think that Helen has included the prospective Lynch syndrome database in her review, which is obviously one of the ones that we look at quite seriously.
Okay, and just a comment is that I think I can say this, I was a clinical expert for the NICE review panel for pembrolizumab, and it's really fascinating how NICE do qualities, but if I told you that the cost of Pembra, as I said, was £8,000 every 3 weeks, and that's therefore about £300,000 for 2 years of pembrolizumab, that's just the cost of the drug, divided by 30,000, that's, you could think that you extend your life by 10 years by by having immunotherapy, which is not definitely true yet. It was amazing that they agreed to fund it without overall survival data, just on the very impressive progression-free survival data. And I would just, as a comment, and I was interesting about for patient advocates, the two most powerful people on the panel to advocate why they should do it were two Lynch patients. I think one guy you know called Mo, and another woman who basically had gone through horrendous amounts of treatment, chemotherapy, radiotherapy, then had immunotherapy, and were alive only because of immunotherapy. So, I mean, it just shows you that nice are nice sometimes. They don't have to do the horrible things they have done in other types of cancers. But I'm just interested in the floor. I mean, if you look at this data for the women, if you had to sit in front of NICE and say, do you think that this is something that you would advocate? This is very different, right? Risk reduction surgery is not the same as treatment for metastatic treatment. So I'm opening it more to the floor for the advocates. How would you want to sell this to NICE and saying, we really want to do this?
Yeah. Sorry, I am that annoying person who says I'm not having surgery, and I'm
no, it's not annoying. That's entirely.
And I am the only PMS2 one, but I've been having surveillance for 12 years, and every sort of 5 years I psych myself up for surgery, and then the guidance gets studied, and they say, let's up it again. It's like, so when I first got diagnosed with Lynch, they said recommended age was 30 or when you've had children. So I was like, okay, I'll have my children, then I'll have a hysterectomy. That came and went, and I was like, okay, now the guidance is 40. So I waited till I was 40, and I've got it all in place to have it done late this summer. And now the guidance is saying 50, and I'm like, oh, so shall I wait another 10 years? Yeah, so is that just a study, or is that what the guidance is, 50 plus now for PMS2? It was a slide you showed quite early.
Yeah, this is, so these are the findings of a study in the US. This is on the basis of what is economically optimal from a health payer perspective. So this isn't necessarily saying what's going to be the best for the average patient in terms of quality adjusted life expectancy, because it might be that the best way to get somebody quality adjusted life expectancy is too expensive. So this is the best thing that you can get that we can afford. Also, it varies from patient to patient. Patients are entirely within their rights to have different preferences for different things. You might place a lot of weight on certain things that the average person doesn't, and that is fine. Nobody should tell you that you should decide this because, on average, this is what people think. You're your own person. And the decision to have or not have risk-reducing surgery is a big one. And I think, I'm not a medical doctor.
Can I just follow up? You mentioned the PLSD there, Tristan, and I've just looked up yours.
Yeah.
If anyone hasn't used it, if you look at plsd.eu, plsd.eu is our website. We've got 8,500 people being followed prospectively by gene, by organ, so you can put your age in, and in this case I've just looked up for PMS2. So basically in our 8,500 people, admittedly PMS2 is relatively small in number, partly because they're harder to find, but there are no endometrial cancers before 50 in our follow-up. So that's the graph that drives it.
Begs the question, why am I bothering to put myself through surgery?
Well,
for another 8 years or whatever?
Yeah. So basically, it's you can sort of look up your own risks for each of the tumours.
Yeah,
it's quite useful.
it's difficult for me to say if I was you because I'm not you in so many ways. But many of them to your benefit, not mine.
Let's count the whales.
I would say waiting until you've perhaps had natural menopause to avoid the surgical menopause when your risk is quite low would be an entirely justifiable decision.
I'm not anti-surgery, but it's like, if it's not really going to benefit me, why put myself through?
Yeah, well, there's going to be 10 people have a surgery for every one person that actually benefits from it. If your risk is 10%, that's the sort of, or 9 people are going to, that's the sort of numbers that you might think about. Ian?
Yeah, one point I've got is that as a pathologist I know that ovarian cancers are very complicated. There's many different sorts, but basically they fall into ones that are called serous, because of the kind of structure they've got, and non-serous. And serous are the nasty, dangerous ones that occur in BRCA1 and 2, and non-serous tend to be the ones that occur in Lynch syndrome. So the prognosis and effects and the treatment will be quite different for those than the serous ones. So it would be, I mean, basically you have to distinguish that, otherwise the first person who reviews the paper is going to say,
well, that is going to be one of the
you're
things
not doing
that,
like with like.
that is one of the things that I'm going to have to improve on existing work on, is that existing studies assume survival from general population, whereas I'm going to have to look at survival in people with Lynch syndrome.
And that data is in PLSD as well. For ovarian cancer, it's like 80%. It's way, way better.
Yeah, much better than sporadic ovarian cancer. And that was serous without an I, so we're not saying that there's non-serious ovarian cancer. It's all serious. Some of it is non-serous.
Thanks for that.
Hi, Tristan. Good to see you as always. Just a quick question. In the right study, MSH6, it's suggesting ovary removal at age 50, and then it talks earlier about the risk of ovarian cancer in MSH6. But in the Royal Marsden book, which I know you now have a copy of, I don't know where they get their data from, they consistently say that ovarian cancer risk in MSH6 is similar to population and that there's no risk. So why would you suggest that the ovaries need to come out?
So I would again look at the PLSD and make the decision for yourself what the risk is based on the best quality evidence, which is PLSD. Beyond that, I mean, the reason why you're delaying the ovary removal to age 50 is to hopefully have it peri or post-menopausal, so that you avoid surgical menopause.
Yeah, because there's a disbenefit to losing the calcium in your bones and all that lot. So you have to weigh it up that it isn't all good.
But the PLSD says much the same thing. There's almost no ovarian cancer in our MSH6s until after 65.
Back to the money. So I would just say that, of course, in America, I'm sure the cost of this is $100,000 because it is, everything is more expensive in America. I mean, I think 10 years ago they said if you want a prostate operation, it costs $250,000. I'm pretty sure it doesn't cost even £200,000 to do a prostate operation in the UK. So I think we should be a little bit careful about this quality of $100,000 in America, saying that's quality of life. You know, in the UK, I'm not saying we're cheap as chips, we've got good quality surgery, but I don't know what the cost of an operation is in the UK for doing these things. I think it's probably going to be less than £20,000. I don't know.
So the main, so with the risk-reducing surgery, obviously that will have an impact, but also the cost of surveillance is going to be an important one. So I would always be hesitant to say, let's just use a currency conversion and somebody else's study.
I'm not saying you would. Just for the audience, I mean, we've got to be very careful. My wife's an ophthalmologist, and in India, a cataract operation is literally 2 minutes, and it costs not a lot of money. If you do it more fields, it takes you 40 minutes, and it probably costs a ton of money. So I think it's just really important to understand the kind of world socioeconomics. Remember, everything is about affordability, because this is where NHS comes in. They don't say things are ineffective, right? They say the cost effectiveness, whatever, is whether society agrees it's affordable for their society to have treatment.
And so I would say, as a patient, don't worry about how much it costs the NHS. If the NHS is willing to give you something and it's what you want, take it. I don't want any patient to say, oh, I'm not sure I should because it's expensive. If somebody else has made the decision that it's worth spending the money, so you damn well take it, if it's what you want. The decision also isn't taken by your face-to-face clinician. They're not going, I could offer you this, but I won't because it costs a lot. If it's something that they can offer you that will be paid for by the NHS and it's suitable for you, they will. They're not going to decide on a patient-to-patient basis on the basis of costs. It's going to be about what's best for you. decisions about cost come at department and hospital and local commissioning level. So just, this is for your interest, and if it's shown to be cost effective, that can help you in your campaigning. But I don't want anybody to think that you as a patient have to worry about cost.
And on that basis, I don't know whether NICE sort of do this. You might be able to say, Kai King, but 1 in 30 bowel cancers are due to Lynch. 1 in 30 endometrials are due to Lynch. It's a similar proportion for ovarian, so they're probably thinking, this is 1 or 2 or 3% of the phenomenal budget we spend on the other 97 out of 100, and they're a small special group that deserve particular care that will benefit them hugely and save us having to spend on them later.
Yeah.
So it's kind of a no-brainer.
I mean, that came up at night.
Did it?
The whole idea that
Right.
you gave it to them. And one, you help maybe stimulate more testing. I'm sure
Yes, yes.
And protect more Lynch families, and therefore protect more babies. There's a kind of paying it forward benefit, and also this whole thing about protection. So if these people get immunotherapy, they won't get the second. And I just showed you some cases where one, maybe that pancreatic patient will not get a 9th cancer, and also in the neoadjuvant setting, maybe again they will prevent them getting other cancers in the future. Women having neoadjuvant immunotherapy won't get endometrial cancer, maybe.
Question down here.
I cannot take any further questions.
We've got to have one more because all the male doctors were speaking.
Thank you. My question was that my understanding prior to today was that surveillance for gynecological cancers was not very successful, and that women opted to go for that rather than having risk-reducing surgery because either they were still intending to have a family or because they were at an age where going through surgical menopause would have too many negative impacts on their health. Is that correct?
I would say that's broadly correct, yes.
Thank you, Tristan.
Cheers.